Okay, let's talk about corneal and conjunctival foreign bodies. Now, the patient will come with a foreign body sensation, history of trauma, tearing, and um, for the signs, you might see critical signs like conj or corneal foreign body with or without a rustering if it's in a metallic foreign body, like you can see in this picture. Other signs include conjunction, lid edema, mild AC reaction, SPK, small infiltrate surrounded by a corneal body, and it's usually reactive and sterile. Vertical oriented linear corneal abrasions or SPK could indicate that there is something under the upper eyelid, like you can see in this picture. So take care of that. Now, we've covered the symptoms and the signs. What about the workup? What do we do? Well, first of all, you're gonna have to dig deep in the history and ask everything you need to know. The mechanism, was the patient injured with a metal striking metal, for example, a power tool, or a weed whacker? These strong instruments could indicate an intraocular foreign body, like you can see in this picture. So definitely rule that out. A direct pathway with no safety glasses, distance of the patient from the site, and you should definitely measure the size and ask about the weight, velocity, force, shape, composition of the object itself. So try to ask everything you need to ask in the history. Now, second thing you want to know is the visual acuity of the patient. You should document it before any procedure is performed. Just apply 2 drops of topical anesthesia because you want to control the pain and the blepharospasm. Third thing we want to do is, of course, a slit lamp exam. So you want to locate and assess the depth of the foreign body and try to find any possible entry sites. Rule out self-sealing lacerations. Check the pupils for irregular pupils, iris tears, transillumination defects, capsular perforations, lens opacities, hyphema. Check the AC for any shallowing or even deepening if it's the case of a scleral perforations. Definitely check the IOP. If it's asymmetrically low in the involved eye, this should definitely raise some red flags. Now, sometimes there may be multiple intraocular foreign bodies if it's a powerful equipment or explosive debris. So that's why we need to dig deep in the history. If you don't find any evidence of perforation, evert the eyelids, like you can see in this picture. You never know what you can find. Try to be thorough with your examination. Inspect the fornices. You could even double evert using a Dismar's eyelid retractor. Carefully inspect a laceration to rule out a scleral laceration or perforation. Measure the dimensions of any infiltrate, the degree of any AC reaction, because you want to monitor the progression and therapy response later on if there is a possible infection. Now, if there is an infiltrate accompanied by a significant AC reaction, purulent discharge, extreme conjunctival injection pain, what does this tell you if all these signs are present? Infection. So, if there is an infection, you should definitely culture and make sure to treat it aggressively with antibiotics and follow it up intensely. The fourth thing that we should do is we should dilate the eyes. You want to examine the posterior segment for a possible intraocular foreign bodies. Like you can see in this picture, this is an intraocular foreign body. You should consider a B scan or also a CT scan, axial and coronal views, 1 millimeter sections, or even an ultrasonographic biomicroscopy to exclude any intraocular foreign bodies. Now, what about MRI? Do we do that? What do you think? No, we should not use MRI if there's a history of metallic foreign body. That would be a complete disaster and basically a nightmare. Now, we talked about the workup and everything we need to do. Let's talk about the treatment, and we are going to talk about the conjunctival foreign bodies, and we're gonna talk about the corneal. But let's start with the corneal foreign bodies first. Now, if there's a corneal foreign body, you should apply topical anesthesia, and basically try to remove the foreign body, either with a spud, fine forceps, small gauge needle, at a slit lamp, of course. Multiple superficial foreign bodies sometimes can be removed by irrigation, so that will be your judgment. If there's concern for a full thickness corneal foreign bodies, you should explore and remove it in the OR. Okay, if there is a rust ring, as you can see here in this picture, try to remove it as completely as possible on the first attempt. This may require an ophthalmic burr, as you can see in this picture. It's sometimes safer to leave a deep central rust ring because you want to give it time to migrate to the corneal surface. That will be much easier for you to remove it later on. You should measure the size of the resultant corneal epithelial defect, and you should treat as a corneal abrasion. And we talked about that in the previous video. Of course, you should alert the patient to return ASAP if there are any worsening symptoms. You should instruct the patient and tell him to do so. Now, if there is a residual epithelial defect from the corneal foreign body, is it okay to give erythromycin ointment? No, you should not give erythromycin. Why? Because it's not powerful enough to cover. It doesn't have enough antibiotic coverage. It's not strong enough. This is why you should not give erythromycin ointment. Now, we're finished with the corneal foreign body treatment. Let's talk about the conjunctival foreign body. Same thing, you should try to remove it under topical anesthesia. If it's multiple and loose superficial foreign bodies, do saline irrigation to make your life easier. If you think you can remove it with a cotton-tipped applicator soaked with in topical anesthesia or with fine forceps, then do so. If it's deeply embedded, consider pre-treatment with a cotton tipped in phenylphrine 2.5% because you want to reduce the conj bleeding. Small, inaccessible, buried subconj foreign bodies sometimes can be left without harm unless they're infectious or pro-inflammatory. This will make your life easier because they may be removed more easily. They will surface with time. Now, sometimes you could do conjunctival excision if it's indicated. If you think it's a chemical burn or some sort of chemical element to the history, then you should definitely check the pH. There could be alkali from fireworks, for example, so why not check the pH? Definitely sweep the conj fornices with a glass rod or cotton tipped in topical anesthesia to remove any remaining piece. Rule out conjunctival laceration. Definitely give topical antibiotics, for example, bacitracin ointment or trimethoprim polymyxin B drops or fluoroquinolone drops QID. Lastly, you should give artificial tears if the patient needs it for irritation. That is it for the treatment. Lastly, follow-up. Same thing for corneal. You should follow up as with corneal abrasion, and we talked about that in the previous video. If there's residual rust ring, reevaluate it in 24 hours. For the conj foreign body, follow up as needed, or in 1 week if there's residual foreign bodies that were left in the conj. That is it. Thank you very much.